Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Welcome to another episode of the Oncology Revolution Podcast. My name is Raquel Maris. I'm an occupational therapist and project coordinator at the European School of Lifestyle Oncology. And today I will be the host, joined by Alexandra Hill, a physical therapist with advanced training in both women's health and oncology. She specializes in pelvic health, lymphedema, and cancer rehab for all genders, and leads Oncopelvic PT, where she's changing the way we think about pelvic care in oncology. Alex, welcome. So glad to have you here.
Thank you so much. I'm really excited to be on the podcast today.
Thank you. Let's start at the beginning. What led you to work in the intersection of pelvic health and oncology?
So it was really interesting for me in physical therapy or PT school. I hadn't really heard about either of these specialties. I knew that they were kind of out there, but not really what they entailed. And so I got interested in them and started shadowing with some of the pelvic PTs, and they all also worked with cancer survivors. And so for me, from the very beginning, if you're a pelvic PT, you are also an oncology PT because there's so much overlap. And I found that the impact that we could have with our patients in just a single visit with just validating their feelings and what they're going through and educating them about what their symptoms are, why they're having them, and what we can actually do about them it was so profound for me. I knew immediately that I had to get into these specialties.
That's such a nice story. And how is your current work structured right now? Do you split your time between clinical care, education, and advocacy? How does that work?
Yes, I do. So I currently work at a hospital-based system, and so we see all sorts of people from a very large area. We're a pretty large hospital system. I'm here in Florida in the United States, and I also have my side business, Oncopelvic PT, and so my time is really split up between clinical care, where I see pelvic health, oncology, and lymphedema conditions. I do a lot of online content, so I have a YouTube channel and Instagram. So, really trying to improve the access to good quality evidence-based information that people can trust and can rely on, especially because there can be an issue with access to care to oncology rehab providers and pelvic health providers. And then I also do online continuing education courses for clinicians to try to bridge that gap a little bit more. And in terms of the advocacy, I feel like that's every day, either from a one-on-one level with our patients and advocating with their insurance company about, hey, they need this device or they need this extra referral, to, writing to our lawmakers about, ways that we can advance and protect our patients and our profession in rehab.
Well, and I might add that you are doing a great job, especially in your page in Instagram. It is an amazing content. Let's
Thank you.
level things up, and it's okay. Thank you also for doing an amazing job. Let's clarify for those who might not be familiar with this area. Let's cover some basics first. Can you explain what the pelvic floor and what functions it supports in the body?
Yes, absolutely. And if this is something that you're watching as a video, I do have a pelvic health model. I, of course, have one everywhere. My husband's always like, why is there a pelvic model on the couch? So if you're watching the video, so this is the pelvis. So the pelvis and then the pelvic floor muscles sit at the bottom of the pelvis. And so you can think of them kind of the floor of your core. So we talk about the core muscles, we think about our abdomen, but that also includes your back muscles, the diaphragm, and these pelvic floor muscles. So these pelvic floor muscles have 5 primary functions. They help to support all of the organs. They help to stabilize the entire lumbar and pelvic girdle area. They have a sphincteric function, so they open and close when it's time to go to the bathroom or not time to go to the bathroom. They have a sexual function in terms of enjoyment, pleasure, erectile function. If there's pain, this is where we can have some dysfunction with the muscles. And then they also act as kind of a sump pump. So they help with local and regional circulation in the pelvic area. And so that can come into play, especially when we look at pelvic cancers and lymphedema associated with cancer treatment.
Thank you for breaking it down so clearly. Let's clarify now, why is pelvic health so relevant in cancer care?
So, regardless of the type of cancer treatment, the majority of people have something go on with their pelvic floor where there's some type of dysfunction. So, there are some types of treatments or cancers that may be more prevalent in terms of the impact that they have on the pelvic floor and on pelvic health, in particular, the pelvic cancers. But if there is even a systemic therapy, so think of chemotherapy, a lot of times that can cause some GI distress. So that can cause loose stools, maybe diarrhea, maybe can cause some fecal incontinence or leakage of stool. That's something that we can address in pelvic health. With hormone therapy, that can impact libido. It can impact the structures of the pelvic floor, especially those who have a uterus and a vagina, that can cause some thinning of the tissue, some dryness that can lead to increased risk for UTIs and sexual dysfunction. And then certainly, with those localized treatments with surgery and radiation, those are directly impacting not just the pelvic floor, but all of the structures around it. So we think about all the nerves, all of the tendons, the ligaments, the vascular structures, the lymph nodes. Those are all impacted by those localized treatments as well. And unfortunately, even though these pelvic health symptoms are very common among cancer survivors, they're not really talked about. They're thought of as, oh, it'll get better, or, people are embarrassed to talk about it. And so we're seeing, even though really high rates of issues with pelvic floor dysfunction, it's just not getting treated and it's not getting addressed. And so that's, one of the reasons I'm so passionate about this intersection, because so many people are living in silence with these pelvic health issues that we can address in rehab.
Thank you so much. Are there certain cancer types more likely to affect pelvic function than others?
Yeah, so we do see a higher rate of pelvic floor dysfunction and pelvic health concerns with especially the pelvic cancers. So that could be a colorectal cancer, anal cancer, a gynecologic cancer, prostate cancer, bladder cancer. So really anything in that abdominal and that pelvic region, that's going to have a much higher rate of having pelvic floor issues, just purely because of the treatments that are involved. Like I just mentioned, like the radiation therapy, even if it's external beam radiation or if it's a brachytherapy, so it's an internal radiation, that's going to impact those surrounding structures. So definitely the pelvic cancers are seen, that we have a higher rate of pelvic floor dysfunction. But again, we think of some of the other cancers that are, hormone positive. So like breast cancer is one that is pretty prominent. So if it is estrogen driven or progesterone driven, and they're given a type of hormone therapy, that is going to also have a direct impact on the pelvic floor and on pelvic health as well. So, again, in general, the pelvic cancers primarily, but any of those systemic therapies from other cancers can also impact pelvic health too.
For sure. What are some of the most common pelvic symptoms people experience?
So when we go back to those 5 primary functions, the sphincteric, the supportive, the sexual health, the stabilizing, and the sump pump, those can all then become dysfunctions. So especially when we look at the bladder, for example, so prostate cancer. With prostate cancer, they're typically removing the prostate. When they remove the prostate, then the vast majority of people, 90+% of people, immediately after that surgery are going to have leakage. And that can take 1 to 2 years or more to get completely dry. So urinary incontinence or leakage, cystitis or a bladder pain can be common with chemotherapy or with radiation therapy. Urinary urgency, UTIs. For the bowels, that can range from loose stools to constipation, pain with bowel movements. If they've had radiation especially at the rectal or the anal area, then that can lead to a thinning of the stools and difficulty with evacuating. Prolapse, so when the organs start to drop down into the vaginal vault, that's not necessarily something that would be seen immediately after, for example, a hysterectomy, but a hysterectomy does put people at risk for prolapse down the road as well, because they're removing those structures. With the lymphatic system, people can develop pelvic lymphedema. So it can develop in the lower abdomen, in the genital area, and into the legs. So that can be very distressing and very difficult for people to manage with the side effects that are associated with that. And then sexual dysfunction is huge with a lot of cancer survivors. And that really goes beyond just the physical impact of the treatment. You think about the trauma that's involved with getting the diagnosis, of going through these treatments, the stress from the financial burden and missing work, or having to juggle taking care of your kids or your parents or family members. And there's so much, emotional toll to this and on people's mental health and their relationships, that aspect can also impact their sexual health as well, beyond, again, if there is any damage to those sexual structures.
Thank you for clarifying that. And it gives us a great foundation. Now, when someone comes to you for pelvic physical therapy, what does an evaluation typically look like?
So the evaluation is going to be very comprehensive. I always tell people this is the nitty-gritty. The more you can tell me, the more I can help you, even if it feels like it's embarrassing. By the time that they've seen it, like, we've seen it all, we've heard it all, like, the more you can tell us, the better. Especially in the pelvic health side. So what we'll start with is a very comprehensive set of questions to really understand what the cancer history is like, what treatment they had, are they currently in treatment, and do they have anything planned? We'll want to know about what their baseline symptoms were before they started their treatment, and then what their current symptoms are. So for example, we'll go with prostate cancer again. If someone already had urinary leakage, they already had urgency, they already had erectile dysfunction before the prostatectomy, before the radiation, before the hormone therapy, prognosis-wise, they're not going to be as likely to return to that full function as they were before. So we want to know, did you have these symptoms before, and now are they getting exacerbated? We'll ask about all those different systems. So we'll ask about their bladder symptoms, bowel symptoms, or sexual health symptoms, any prior surgeries or injuries in that area, medication checks. So there are a lot of questions that we ask before we even get started. And then, even though we're really focused on the pelvis, we do want to look at the entire body. So we will check posture. How does somebody walk? How do they move? How do they get up from sitting to standing or lying down on the bed? All of these different movements can impact the pelvic floor. We'll also assess their spinal range of motion, their hip range of motion, their strength. And if they did have surgery or radiation, we take a very close look at that scar tissue. How does the scar move? Do you have pain associated with it? And same thing with the radiation fibrosis. And so again, this is all external still. Now, when we get to the actual pelvic exam part, we may do this that very first visit. We may do it the next visit, depending on how much time we have in the visit, and also what the patient's comfort level is. Some people, they've gone through so many things, like one more pelvic exam today is just like, it's just not happening. It's not in the cards. So, people always have the choice of whether they get the pelvic exam or not. It's always helpful to do because it gives us more information. And so when we do the pelvic exam, and again, I'll bring out my pelvic model here. So we want to assess all of the sensation on the outside. We check reflexes. We'll gently palpate these structures in the muscles to see, does any of that cause pain? Do you have scar tissue or fibrosis there? So we do a full external assessment first, and then depending on your symptoms and your anatomy, then we would do a vaginal and or a rectal exam. So it's not like when you're going to, the urologist, you're going to the gynecologist. We're not using a ton of instruments typically. It's usually just a single gloved lubricated finger, and we are palpating all of those muscles and structures. Again, can we replicate what your symptoms are? But then we also want to know, how are these pelvic floor muscles functioning? So how good is your strength? So can you do a contraction or a Kegel? How strong is that? What's your endurance, the coordination? Can you relax fully, or is that hard for you to do? And so all of that gives us a really good picture of what might be going on, what might be contributing to your symptoms, and then help guide us with your follow-up treatments and what may be helpful for you.
Well, that was very clarifying. But still, I think there are some misconceptions. What are some of them? What do you hear more often?
I think for a lot of people come in very nervous about it, especially because it may be painful. So especially for people who already have pelvic pain, maybe they had radiation, it was really painful to have that completed. A lot of people come in already scared that it's going to hurt, or they're expecting that it's going to hurt. And so the very first thing that people need to understand is that it should not hurt. That first exam, do we need to I kind of say poke the bear, like we kind of need to see what's going on, but it shouldn't cause more pain. It really shouldn't, especially in rehab. A lot of people think like, oh, I'm going to rehab, it's going to hurt. No, it shouldn't hurt. So that's the first thing that I always want people to understand. The second thing, like I mentioned, is it is up to you. So is it recommended? Absolutely. It's going to give us a much better understanding about your anatomy, the impact of your cancer treatment, and what we can actually do for you. There are also internal treatments that we can do. So those oftentimes are going to be very helpful, but we do oftentimes have people that are not comfortable doing the pelvic exam, whether, again, it's because they're just not comfortable, whether it's something cultural, they're just at their wits' end with having pelvic exams and having people down in their personal space. And so at the end of the day, it really is up to the patient. It's up to you. Do you go through with this exam? And the other thing is, even once we start, this is ongoing consent. And so if we get started with the exam or the treatment and you start to feel very anxious, you start to feel triggered, start to feel uncomfortable, or it does start to get too painful, then we stop immediately. We don't keep going. We don't keep pushing through. This is not a no pain, no gain situation. So we want to make sure that the patient understands they are in full control. So I think those are some of the primary things that people will, kind of have concerns about. We always make sure that people feel comfortable with it, that they understand why we're doing the exam, and that they feel good to do it, like I said, every step of the way.
That's good to hear. Now let's talk solutions. What does pelvic rehab actually involve? Of course, the treatment would be personalized as the assessment is, but what can pelvic rehab look like in practice?
I love this question because, like everything in rehab, it depends. As you said, everything is very personalized. But typically it's going to very first and foremost involve a lot of education. So we'll go through different behavioral modifications, lifestyle recommendations. That could be anything from reducing bladder irritants like coffee, carbonated beverages, things that might increase urgency or incontinence, to working on increasing your fiber and the type of fiber that would be beneficial for you to kind of bulk up your stool so you're not having as much leakage. We can talk about sexual positions. So if we think about cancer-related fatigue, which the majority of cancer survivors experience, one, it's going to be enough just to get the oomph and the libido to be sexually active with your partner. But then if you're using all of your energy to be in a position that's maybe more energy expending, like on quadruped position, for example, like on all fours, that's extra energy that you may not need to use. And so recommending positions like lying on your side or using pillows to support you, talking about lubricants and moisturizers. So a lot of different things that we can talk about on the education side that that in and of itself is such an important intervention. And for clinicians, I always urge clinicians to not think of education as something passive. It shouldn't just be a handout that you give at the end of the visit and you say, okay, here's the information we talked about. It should be individualized. It should be interactive. It should be a engaging and empowering intervention that you're able to do with them. It's just as important, if not more important, than doing exercises. So education, again, is like every single visit we are educating. The other things that we'll do are therapeutic exercises. So stretches, strengthening, balance exercises. If we do find that you have some neuropathy issues, for example, we can work on cardiovascular training, but a lot of times we'll work on a lot of those kind of central core muscles and mobility for example, the hips and the trunk. And then pelvic floor exercises, of course. So a lot of people think of just Kegels, which are repeated pelvic floor contractions. And that's great for strengthening. But for a lot of people, for example, if you have pain, if you have urgency, if you have fibrosis and scar tissue, we don't only want to be contracting, we also want to be working on lengthening and relaxing the pelvic floor. And so that can be a really effective tool to help people start to manage these symptoms, is really think of it more as pelvic floor retraining and improving the coordination, the strength, and the endurance. So those are some of the primary things that we'll do. We can do a lot of manual therapy, and that can be both external and internal. So if you do have muscle tension, if you have scar tissue, fibrosis, those are all things that we can do externally and internally, again, either vaginally or rectally, depending on what the need is. So those are the primary things that people would likely be expecting in pelvic PT or pelvic rehab. And then, I do have that additional specialty of lymphedema. And so some pelvic therapists are also lymphedema therapists, or at least have a little bit of training in it. And so there can be some interventions we can do for the lymphedema and the swelling as well, to help with reducing that swelling and improving those symptoms.
Well, thank you. I would also want to ask you if you can share a kind of techniques or tools that you use.
Beyond the specific ones?
Yeah, if you use some kind of tools, like
modalities?
I don't know. Yeah.
Yeah. So there are some electrical modalities that can be helpful. So especially for urgency, there's something called transtibial nerve stimulation. So we actually put the electrodes, you can use a TENS unit, but you put the electrodes down at the ankle to stimulate the posterior tibial nerve, and that can help with basically modulating the bladder, and can be really helpful for bladder pain and bladder urgency. So that's one thing that can be really helpful. For patients to use at home, if they've had radiation therapy, then we'll recommend that they use dilators or trainers. And so those are just small medical devices that are either made of plastic or a soft silicone, and they're graduated sizes. I don't have a set with me on my desk, but that basically would help to retrain those tissues and help to get more mobility and flexibility with them. But again, if somebody's had radiation, that's usually something that we want to start usually about 4 to 6 weeks after radiation therapy. So that can be a really helpful tool. I don't do dry needling, but I do have some colleagues that do dry needling. That can be a really effective tool as well. And then different types of tools for manual therapy, whether that be, using cupping or like ISTM tools, that kind of thing. Those are all things that are really helpful.
How do you adjust for people who might be dealing with fatigue and pain or advanced disease?
So we really want to tailor it to the patient and making sure that people understand what their choices are up front. So oftentimes I'll let people know that telehealth is available. So if they do have a lot of fatigue, or maybe their blood counts are really low, they're, have really low white blood cell counts, high risk for infection or for bleeding, and they want to stay home, we can still do a telehealth appointment. where we can still work on some of the behavioral modifications, education, some of the exercises. And it can be really great to do when they're at home anyway, because then we can see what their home environment is and really tailor the program to what they can do at home. So say they have a great countertop, awesome. We can use that for using support for doing lunges to start to strengthen the pelvic floor and the core muscles, but keeping your balance. So telehealth is one really great option. If they have fatigue, then being mindful of scheduling appointments. So not having PTB at the end of the day when they've already had 3 other appointments that day. So either rehab being one of the first appointments, or having it on a day that is just like, that is their one appointment that they focus on. Depending on the fatigue level, then we would modify how intense that session is. So if we're working on, balance and strengthening, that might be a day where we do need to back off a little bit. But with fatigue, we want to make sure that they do understand the benefits and really the necessity of continuing to stay physically active. So those are some of the things that we can do, using a lot of pillows and supports and bolsters in the clinic, while they're on the table for lying down, so they're not having to support their leg. Maybe we do the treatment inside lying, so they're not having to support themselves as much. So those are some of the things that we can do. I also like to, if people are really having like kind of a heightened like fight or flight response, like just a very highly active nervous system, a lot of anxiety, sometimes turning the lights lower or off. And like I have a treatment room that has a lot of really big windows, so we get a lot of natural light in. Sometimes just turning off those overhead fluorescent lights and just having the natural light can be really, really helpful. Having some nice soothing music on, and initially before we even start the session, working on down training that nervous system with guided relaxation, diaphragmatic breathing, some gentle mindful movement before we even get into like kind of the meat of the session can be helpful.
I love how we can personalize so much and make the patient more comfortable. That's so important. Do you have an example of someone who made a meaningful progress with pelvic rehab?
Yes. I had a patient who had gynecological cancer. She had radiation therapy, but her tissues were very stenosed, meaning they were very, very narrowed. They were very dry. They were very atrophic, so very thin, not very mobile. And so even though they had recommended to do brachytherapy with her because that was going to be what they had recommended to be more effective, she refused it. She could not tolerate it at all. And so for her follow-up appointments, she wasn't going to them with her gyn-onc because of how painful it was, how traumatic the whole experience was for her. She wasn't sexually active. She hadn't been sexually active in many years. Using tampons had always been painful for her, even when she was younger. So she had always had a lot of trauma and negative experiences around her pelvic floor. And so her gyn-onc had referred her to see me to work on this because she, like I said, she wasn't going back for her follow-up appointments to check, like we should every couple months, especially those first 2 years out. And I remember she came in and just very tearful, very fearful of why she was there, had essentially kind of given up and was just like, I would rather get cancer again than deal with a pelvic exam. Like it was that traumatic for her. And, that first session, all we did was talk. We didn't get on the table. We didn't we talked a little bit about the exam, but like we didn't go anywhere near that. And we just talked about kind of exploring her feelings and kind of motivational interviewing about why do you want to do this, and how can we do this, and how can we do this successfully for you. And so she did agree to come back, and it only took about 5 visits where we worked on essentially kind of graded exposure with her, getting comfortable with being just first on the bed with me sitting next to her. her being on the bed with my hand on her thigh. So it was just a graded exposure. But by the time that we were done, she was able to use a small dilator or trainer in the vaginal canal, and she had minimal pain with it. And she went back to her gynec and was able to get a pelvic exam with a small speculum. And she started crying because she was so grateful that she didn't have pain with it. And it still wasn't a great experience for her. She still had a lot of, fear surrounding it. But the fact that she was now going to her appointments was just incredible. But again, that goes to really show the impact that we can have in rehab. It's not just, the physical side of things. It's shifting the mindset. It's getting the nervous system on board with the musculoskeletal system as well. But that patient was very impactful for me, and really hit home the importance of motivational interviewing, really understanding the patient and where they're coming from, and how can we meet them where they're at.
Well, thank you for sharing that impactful story. And it really puts things into perspective. And you talked about the gynecologist and the role that you played that was so important for her to continue having those treatments and consultations. And I would love to explore how pelvic health PT fits within a broader oncology care team. So on the collaboration side, when should other professionals think about referring someone to a pelvic health PT?
Immediately. So especially, we think about prospective surveillance model. And this is most often, we have a pretty amazing blueprint for breast cancer, right? We're starting to get that developed for other cancers as well, like prostate cancer and gynecological cancers. Truly, like once somebody, especially if they have a pelvic cancer, it should be diagnosis. They're getting the referrals to surgery, radiation, hemonc, social services, and rehab. We should be right there. We need to be there to be giving education, optimizing their pelvic health before they start treatment. So if they're already dealing with constipation, let's get the constipation managed before you start getting all these pain medications for the surgery, right? There's just so many things that we can do to mitigate a lot of the symptoms that people are going to develop during and after treatment. So if we can have that early touch point, and even if it's just a one-time consult, and then they remember later, oh, hey, I need to go back to see them because I'm having these symptoms, that's going to be really impactful for them. And so, we've started doing that at my hospital system, where they're starting to get patients in to see us earlier, sooner, and the impact and feedback from the patients has been really, really positive. A lot of times in pelvic health, especially in the oncology world, people are always saying, why didn't I know about this sooner? Why didn't I see you 6 months ago? Why am I still having to use 5 Depends, pull-up briefs a day because of my leakage when I could have been seeing you months ago? So I will get on a soapbox for this every time, but we really need to be seeing people like as soon as they have that diagnosis before they start treatment, or as soon as we can after, because sometimes there can be a quick diagnosis and then treatment right away. We might not have time to get that first visit in. But if we can get them like as soon as they're done with treatment, just to start on some of that education, that's going to be key.
For sure. And from your perspective, how can pelvic PTs or PTs in general better integrate into oncology teams?
I think showing up on things like tumor boards, or, if you're in a hospital system or a larger clinic, on the tumor boards or on the cancer committee meetings, rehab at this point in 2025, we shouldn't be an afterthought. We need to pull our chairs up to the table and make our voices heard. I think that's one thing that can be really, really impactful. And even just having your patients, if they did well with you, make sure that they go back and tell the provider, or, when you discharge your patient, send that final note to the doctor with a note of, hey, thank you so much for this referral. these are the successes that we had objectively, but also subjectively, their quality of life. And the medical team, they're going to start to see the benefits of sharing patients with you and working together, because on the medical side, we in rehab, we need to show them how we can help not just the patient, but how can we help you? We can help make sure that your patients aren't having as severe of side effects down the road, so that you're not then having to try to address some of these more severe, more significant side effects, and really showing what our worth is, showing up for in-services, emailing. I mean, there's so many ways that we can really integrate ourselves and work with them. And especially because that standard of care is the prospective surveillance model, and rehab is integrated into that. We just have to keep reminding them, we got to be that squeaky wheel of, really just continuing to shout from the rooftops of the benefits of rehab for our patients.
I love that. Show up, speak up.
Yes.
We're here. We want to help, and we will help. Well, as a rehab therapist, I also agree with you. Let's shift to education and access. What are the biggest barriers to accessing pelvic rehab today?
I think one of them is just the number of pelvic health therapists. So I can speak primarily for, from a US perspective, but we just do not have enough. Even in my area, I have some people that are traveling by car, up to 2 hours to drive to see me. Because especially for something as specialized as pelvic health and oncology. And so that's why, I mentioned earlier that telehealth is a really great option. But I think first and foremost is we just don't have enough pelvic therapists. In that same vein, there are some pelvic therapists, primarily women, who only work with women. And so when we look at our profession as a whole, in the US, we have a lot more women who are physical therapists. And so that's going to lead to an access issue for men, or, anyone who has a penis and identifies as man, to find a therapist. I can't tell you how many men I've worked with, and they're like, I can't believe I finally found somebody that will work with me. Everybody I've talked to only treats postpartum or something. So I think, again, that I think is the biggest access issue, is just the number of therapists that are trained in pelvic health with any gender, and also with oncology. Here in the US, unfortunately, we also do have access issues in terms of insurance. I had a patient the other day, and she had a $150 copay, and that was through her insurance, versus some people might have no copay or $25 copay. $150 copay is just not reasonable for a lot of people, especially if you might need multiple appointments. With our insurances here, oftentimes they need pre-authorization. We need to get it signed off from the physician. There's so many hoops that some of these insurances make patients go through. It's detrimental to them, and it delays their care, with them being able to come in as well. So I think, the insurance and the cost side can be a barrier as well. And then I think the third thing is kind of a combination of awareness. People just aren't aware that this is a thing. And also that this can be very taboo and difficult and maybe shameful to talk about as well. This isn't something that most people, like, you're going to brunch with the girls and you're talking about your leakage and your pain with sex, right? Like, we just typically don't talk about it. I think, especially the last 5-10 years, especially with the rise of social media, people are talking about it. And I think that is helping to break down some of these barriers. So it's not only making sure that patients and the general public are aware of what we do in pelvic health rehab, but it's also making sure that the medical providers understand what we do as well, and how we can help their patients. So I think there's, like I said, kind of three primary things that can impact that access issue.
I agree. And what do you think we could do to build more awareness around this topic?
Talk. Shout it from the rooftops. So, this comes, in rehab and anyone in healthcare, we have to be advocates for our profession, but also for our patients. So this was, for me, one of the driving forces that led me to start Oncopelvic PT. Was I felt like we we as a profession and for my patients, like we needed a platform to start talking about this. And again, having it be in an evidence-based manner, not sensationalized or clickbait or, we want to make sure that people are getting the right information. So I love that pelvic health is talked about so much more. It's trended on, these different social media websites. So I think one thing is just talking about it more from a profession standpoint, and then people just talking about it more in general. As providers, we also have to be asking our patients these questions. So, there's been some studies, and the majority of oncology medical providers are not asking their patients if they're having sexual concerns. So if the provider's not asking, the patient's not saying anything because they're embarrassed, then nobody's talking about it. So I think the biggest thing is just talking about it. There's more research that's coming out about pelvic health conditions and symptoms after these treatments as well. More evidence on the efficacy for rehab, including prehab and afterwards. So I think that that's really helpful too. And then disseminating that research as well, I think is going to be helpful.
Really good insights. And before we wrap up, let's look ahead. If pelvic PT were a standard part of oncology care, what do you think would change?
Oh, only positives. I think that people would be empowered, first and foremost, and going through cancer treatment diagnosis. It can take away a part of you for a lot of people. And so if we can give back this, your empowerment with managing your pelvic health and understanding your symptoms for something that, like I said, it can be embarrassing. It can be shame or taboo. I can't tell you how many patients I've worked with, and they don't tell their partner that they have pain with intercourse, and they just kind of bear through it. But if we can really empower our patients, I think that that's going to be first and foremost one of the most impactful things, that if we are integrated better into oncology care. And then second is, these acute, late, and long-term effects, we can mitigate a lot of those, again, with some of those interventions that we talked about already today.
Thank you for that. And finally, your key message. What would you want every patient and health professional to know?
Take care of your pelvic floor, whatever that means to you.
Well, that is amazing. Alex, thank you so much for sharing your expertise and shedding light on a part of cancer care that is too often overlooked. Pelvic health is a core part of quality of life during and after cancer treatment. And to our listeners, we hope this episode encourages you to think more holistically and to advocate for care that sees the whole person. Thank you so much, Alex.
Yes, thank you so much for having me on. I really appreciate it.
Thank you.